Now, what is the osmolarity? The total solute concentration, either that is penetrating and not penetrating solute in a solution, is actually the osmolarity. And what actually osmolarity is that it determines the water movement either into the cell or either out of the cell. Now we have the three type of the osmolarity conditions within our body. First of all is then isotonic. Then as the name suggests, in an isotonic, the extracellular fluid osmolarity is same like that of the intracellular fluid osmolarity. Like you will see in the kidney's proximal convoluted tubule of the nephron, the same amount of the H2O that is absorbed in proximal convoluted tubule, like 65%, exactly same 65% solute sodium is reabsorbed. All right, so that is an isotonic condition. And same, meanwhile, exact amount of the water and the solute is going to loss from the lumen and getting reabsorbed back into the blood. So it's a type of an isotonic condition. There is a no change on effect on a cell because the exact amount of the solute that is lost is equal to the water loss. So it's a perfect condition. The abnormality is with the hypotonic and the hypertonic. Whenever we are talking about the hypotonic, we are actually referring the condition of the plasma, not the cells. In hypotonic, what happens in the osmolarity that extracellular fluid osmolarity decreases down. And why decreases down? Because there is a more solute loss than water loss. Now, what happened to the cell? Like cell swelling. Why? Because in extracellular fluid, their osmolarity is less. However, within the cell, there is more osmolarity, and there is a tendency for water to move towards that area where there is an increased osmolarity. So, whenever the osmolarity of the plasma drops, then that fluid from the plasma get moved into the cell where osmolarity is more compared to our plasma. So that is the reason in hypotonic our cells swell down. Next is the condition is a hypertonic. Hypertonic condition, you have an increase in extracellular fluid osmolarity. And why? Because whenever there is a more water, remember it, the solution is hypotonic. And whenever there is a more solute, there the solution osmolarity is hypertonic. So what happened? Either the solute is more or either water loss is more. Either the solute concentration is more or either the water loss is more. Both these conditions results in a hypertonic. Like a hypertonic condition, you can see in one of the pathology in which our body didn't secrete or the effect of the ADH. So what happened that the water is not going to absorb and all of the water get lost from the body and the solutes are more when water is losing and in results our body osmolarity is increases and hypertonic. I have separately explained it on another slide too. Now moving towards our another conditions, what is in the dehydration, how there is the osmolarity increases. Now we know that in dehydration there is more water loss compared to the loss of the solute. Example in diabetes insipidus. In diabetes insipidus, there is the no ADH effect. Mean ADH is not going to reabsorb the water back into from the your nephron's lumen back into your blood. So what will happen? All the water that is the lumen is going to be wasted in your urine. In result, your water loss and total body water loss is more, and however, the solute loss is not that much. So in results, our osmolarity increases. That is the case of the dehydration and in diabetes insipidus. So most of the students get confused between that scenarios because they are confusing actually between the osmolarity of the urine and osmolarity of the plasma. You have to differentiate first that whether they are talking about the urine and the plasma, because these are both opposite. For example, in insipidus, the urine osmolarity is low. However, the plasma osmolarity is high because there are more salt retention. However, why urine? Because in urine there is more water content that is being to get lost from the body. So that is the reason. First, you have to locate out it's whether it's serum or the urine. You have to differentiate between two, and when you will master it, trust me, you will never ever get your question wrong. Next, moving towards the condition of the hypotonic. Same, both are the cases of the dehydration. However, in the hypotonic, how hypotonic? There is syndrome of inappropriate ADH. In that condition, your body is secreting excessive amount of ADH. What ADH will do? It will reabsorb a lot of the water. What will the solute concentration in your blood is same, but now more and more water is going to add it in your plasma. So what will happen? That solute concentration, which even is normal, but now due to the excessive volume, the osmolarity and decreases, which results in the hypotonicity. So in that condition of the syndrome of inappropriate ADH, water gain is more compared to the salt. So in that again case, osmolarity of our plasma is low, hypotonic. However, the osmolarity of our urine is high because all of the urine that was in the lumen is now absorbed. What left behind in the lumen is solute. So it will increase the osmolarity of urine. Now, the last one is an isotonic fluid loss, and you will see in the hemorrhage because the equal the sodium and the water is going to loss from your body. So, first of all, you have to know, because there are the arrow question you must get in your real form related to your osmolarity, and you know in which section there are isotonic, in which section there are hypotonic and hypertonic. First of all, as I have clearly explained, in proximal convoluted tubule, there is a 65% of the filtered water and solute reabsorbed isotonically. Whatever will be the condition, either body is in dehydrated state, either body has an excess ADH, either the body has no ADH. Always remember the osmolarity of proximal convoluted tubule is same. They will even I will further explain you. They will check your concept. Like they will give you excessive dehydrated state and even ask you that what will happen to the osmolarity of the PCT. Always remember there is no change in the PCT osmolarity whatsoever. Now, next moving towards our descending limb. What happened in descending limb? In descending limb, only there is a water permeable and no solute reabsorption. So now when you say in here is a lumen, like you say that is the lumen. And here was an equal amount of the solute and water, but now the water is going to loss. So in that lumen, what left behind is that there are only in solute. So what will happen? All those molarities dependent on the solute. So you will continuously see that whenever it is moving from upward to down deep into the medulla, the osmolarity is continuously increasing until it reaches the 1400. However, medullary concentration osmolarity is here decreasing because now the water is being added that is going to like buffer the solute. So here is the point that the student confused, because the osmolarity of the lumen is different, osmolarity of your medullary interstitium is different. So in the scenario, you have to focus which osmolarity they are even talking about. Next is this descending limb. Descending limb is an impermeable to the water, and here is only your triport pump, that is the sodium, potassium, and the chloride reabsorption.
I'm
So,
sorry, Dr. Lena. Can you
Yes,
explain the descending limb again? I'm sorry, I don't I got lost with the permeability and like what's the difference between in the tubule and outside in the medulla.
all
Like I
right.
got a bit confused. Sorry.
This is a descending limb. All right, you are seeing, and it has a permeability that only the water is going to get lost from the lumen, and that is the medullary interstitium. All right. That descending limb is impermeable to solute. Here, which thing have to move out is your water. And as we know that our osmolarity is dependent on solute. So whenever there are equal amount of the water and solute, the osmolarity is equal 300. However, as the blood passing down the loop of the Henle, water is moving outside the lumen into the interstitium. So what is only left behind in that from moving upward to downward is solute, because water is not, the solute is keeping on concentrated, lumen is keep on concentrated, because water is getting absorbed into our medullary interstitium. So what will happen, water when keep on reabsorbing, that osmolarity then within our loop of the Henle will keep on increasing from 800, and whenever it reaches the 1400, that excessive amount of our water has been reabsorbed, that in our lumen only the solutes are left behind, and that solute is going to increase your osmolarity. Always remember, whenever the more water is added, your osmolarity is going to decrease. But whenever your water is lost and you have left behind the concentrated solute, your osmolarity is going to increase. All right?
Yes, so it would be that like going down the loop of Henle, it's getting more concentrated, right? Because the water is
Yes,
leaving. And so and then the medulla it's getting more like less
water.
concentrated, right? Because there's more water.
Yes,
Okay, thank you so much.
no problem. Now moving towards the ascending limb. Here it is impermeable to water. Now water has no access to move outside. Only what is moving is your solute. That is the tripod pump. So what will happen in now moving upward like that, your solute moves outward. In that, what left behind is your water. So what will happen in your osmolarity? Ultimately, your osmolarity decreases because your osmolarity is dependent on solutes, and in that section you are losing your all the solutes. However, when we talk about the osmolarity of medullary interstitium, it's going to increase. Why? Because it is getting more and more solute from the lumen. So that is the case the student confuses, because the conditions are different. In one thing, that is the loop of Henle, the osmolarity is decreasing because of the water, because of the loss of solute. However, in medullary interstitium, the osmolarity is going to increase because they will gain access to more and more solute. So here there is no reabsorption of water, and only solute is going to reabsorb. Then we will reach our that limb, that is the distal convoluted tubule. Again, distal convoluted tubule is an impermeable, and only the sodium reabsorbed, and your osmolarity gains from 150 to drops to 100, because in distal convoluted tubule, more solute is now again to reabsorb, and that is losing from the lumen. Lumen is keep losing on solute, however, water has fixed amount. So that's why osmolarity is going to decrease. High yield point, and even there it is mentioned on the MBME that the least osmolarity in the absence of ADH is that they will not give you GCT, they will simply give you that diagram, and in that diagram you have, they will give you option like A, B, that C, D, and E, and they will say in which of the segment there is a decreased osmolarity. So always remember, whenever there is no ADH, distal convoluted tubule of Henle has the least osmolarity in the nephron segments. Now, we will move all the scenarios that are in normal physiologic. Now we will say what will happen when there is a dehydration state and there is more ADH release. Now, what will ADH do? Actually, that ADH antidiuretic hormone inserts an aquaporin V2 receptor. And now the water reabsorb into the medulla and the lumen and have more solute concentration so that the osmolarity, like you will say, our that limb that is the collecting duct that is impermeable to water in absence of ADH. However, whenever body is dehydrated state and our plasma osmolarity, again I'm mentioning plasma osmolarity is high in dehydration state, again because no water and increase in the solute. So what will happen that it will signals to the hypothalamus, hypothalamus signals to the posterior pituitary, and posterior pituitary release of ADH. What will ADH do? That ADH will here come and in that side from the medullary interstitium side in the collecting duct, it will incorporate the aquaporin 2 receptors. What aquaporin 2 receptors will do? All the water that is in the lumen is now getting absorbed into the medullary interstitium because body is dehydrated state and the body can't afford the loss of the water into urine. So that is the reason. Now you would say that here the water is keep on losing. However, there is no access for reabsorption of solute in your collecting duct. So what will happen? Water will keep on losing. Solute is there in the lumen. So only in the presence of ADH, the osmolarity of your lumen will even reaches up to the 1200 milliosmol per liter. However, always remember that whenever there is no ADH, that uh, osmolarity will not reaches the 1200. All right, it's only in the case of ADH that collecting duct osmolarity is reaches up to the 1200. How ADH will do? Actually, ADH increase the expression of the urea transporter in your inner medullary collecting duct. So, increase in the urea reabsorption. What will urea do? Urea act as an osmolar agent. Now, I will explain. ADH come and ADH here incorporates first of all urea transporters. More and more urea from the lumen when reabsorbed into your interstitium osmolarity increases. And whenever I have seen you that segment which have increased osmolarity, water will move towards that segment. When the water in the lumen sees that instead of in the lumen, in the medullary interstitium, I have more osmolarity. So ultimately, your that water which is impermeable in the absence of ADH will now move into your interstitium, get reabsorbed, and that osmolarity is keep on increasing within the lumen because now water is going to lose and solute is still present in your lumen. So, because that urea increase your osmotic gradient and which increases your H2O reabsorption. Without ADH, there is no aquaporin insertion. So, in the absence of ADH, our collecting duct is impermeable to water. So, water will keep on stay in the lumen and osmolarity will same either to the 50 and 100 milliosmol per liter. So, you will see that in case of ADH, osmolarity of collecting duct reaches even up to 1200 milliosmol. That is the high yield point too. And I have again explained that slide too.